Good morning, Mr. Chairman, colleagues. It's really a pleasure to be here. I want to thank the new team of the Cardiomyopathy Association, Professor Elliott, for inviting me. My task is to talk about the heart in disorder of cardiac metabolism. And, well, this is really a difficult topic. I will try to highlight these 3 points. So starting with definition and classifications, then going to clinical presentation, diagnosis and management, and then defining the role, our role, the role of cardiologists in metabolic disorder. So, first question is, what is a metabolic disorder? It is a congenital or inherited disorder of biochemistry, and we look to a small molecule like carbohydrate, protein, lipids, and nucleic acids, and organelle disease, particularly lysosome storage and mitochondrial diseases. These are really rare conditions with a multiple inheritance. Generally, it is autosomic recessive, but it can be also X-linked or matrilinear when an abnormality of mitochondrial protein are involved. And clinical presentation can be really heterogeneous with encephalopathy, metabolic acidosis, hypoglycemia, acute liver disease, particularly in infants and children. And cardiac involvement can be really broad, both in children and adults, particularly with the heart muscle disorder, different types. All types of cardiomyopathy may be encountered in this patient, but particularly the hypertrophic type. Valve disease can be part of the spectrum in some specific disorders, particularly LSD, lysosomal storage disorder, and ECG abnormalities where before can be part of rare disease in general and metabolic disease, particularly ventricular arrhythmias and conduction defects. Looking at the heart, so we will concentrate on conditions that can give us heart problems and cardiac involvement. And so we will look at GSD, fatty acid oxidation defects, LSD, and respiratory chain defect, the so-called mitochondrial condition. And we will have a brief look to the clinical presentation of this condition. Starting with GSD, this is a very wide group of disorder, included the so famous particularly for pediatric cardiology, POM disease. But we have quite few autosomic recessive disorder that can give heart problems. And also a couple of disorders, I won't go through this disorder because we will speak later on about them. PKG2 disease, there is an autosomic dominant disorder, and GSD2B, the so-called Danon disease, there is an X-linked disorder, and they share a common phenotype with POM disease, with hypertrophic cardiomyopathy, conduction disturbances that sometimes can be progressive. So let's concentrate on this condition. This is a very rare condition that was described in 1932 by a pathologist who described the case of a child with muscle weakness, important hypotonia, and idiopathic hypertrophy of the heart. This was found to be related to mutation in a gene encoding for alpha glucosidase. This gene is responsible for the catabolism of glycogen, and the net effect is a glycogen storage disease in lysosome. Of course, lysosomes are everywhere in our body, but the phenotype is mainly heart, muscle, and a respiratory phenotype. And this phenotype can be really aggressive in infants with a severe cardiomyopathy, a severe hypotonia, while the phenotype in childhood is less severe, is similar but less severe. And in the clinical setting, we can have red flags looking at ECG, the ECG of children and infants is a typical ECG with very high voltages, with left ventricular hypertrophy and short PR that are red flags of this condition. And if we look at echocardiography, we have a massive biventricular hypertrophy, sometimes with an hypokinetic left ventricle. And we really need to recognize this disorder as soon as possible, because we have a treatment. Without treatment, this can be really life-threatening. But what happens in adults with pump disease? Well, you are not likely to see as first a late onset pump disease, because this is more similar to a limb-girdle dystrophy. So probably a neurologist will refer this patient to you, but there are data coming out that a vascular and aortic phenotype is part of the spectrum, and there are also anecdotal description of aneurysm and dissection related to these aneurysms. Just briefly on fatty acid oxidation, these are autosomic recessive disorder, very rare, coming in clinic with hypertrophic cardiomyopathy, severe arrhythmias, and the risk of sudden infant death. And similarly, we have carnitine defects, primary or transport defects, with generally hypertrophic cardiomyopathy, and again, ventricular arrhythmias that can be really life-threatening. In adults, the phenotype is smoother and less known. LSD is probably one of the most important group of disorder. I will highlight the fact that many patients with LSD do not share with other disorders the myopathy. But we need to remember that the pump disease and Danon disease are also lysosome storage, so they are an exception. We will concentrate on Anderson-Fabry disease and MPS. Anderson-Fabry is mainly an adult disease. MPS is more a pediatric disease. Anderson-Fabry is an X-linked disease related to a deficit of alpha-glucosidase, and the net effect is the deposition of glycosphingolipids in different cell tissue, particularly skin and kidney in really early in life, while heart and brain are an evolution of the disease. Generally after 30-year-old, so in young adults, we can start to seeing cardiac involvement. And this cardiac involvement is typical an hypertrophic cardiomyopathy, generally a concentric hypertrophy, with an hypertrophy also of the papillary muscle. This has been described really recently as a typical condition in metabolic and storage disorder. The valves can be also thickened, both aortic and mitral valve, and recently also an aortopathy has been described in these patients. Diagnosis is mainly related to the phenotype, cardiac phenotype, and mainly proteinuria or kidney involvement. And we need to remember that the diagnosis is related to measurement of the enzyme in males, while in female carrier, the enzyme is not enough, because female are a mosaicism, and so the enzyme can be normal. And so we really need genetics to have a diagnosis in female. Prognosis is related to, of course, to the stage of the disease. So a cardiac and kidney advanced disease has really poor prognosis, and even therapy is not enough to reverse the phenotype. While looking at cardiac outcome features, we know that the severity of hypertrophic cardiomyopathy is an important determinant of the outcome, and we need to look at the mass, left ventricular mass, the extension of fibrosis, the presence of arrhythmias, and also there are data coming from the London group that some cardiac variants can be more progressive related to a more progressive phenotype. So MPS, this is a very wide group of disorder. Is more let's say, pediatric group of disorder related to a storage of gag material, dermatan sulfate, heparan sulfate, and so on. And particularly MPS 1, 2, and 6 are the most involved with cardiac abnormalities, and cardiac abnormalities can present with hypertrophic cardiomyopathy, with AV blocks, they can be progressive, with arthropathy, with premature coronary artery disease, but particularly valve disease. Valve disease is probably the most common abnormality in these conditions. So, mitochondrial disease, this is a very huge group of disorder. You heard about it from Jerry before. These are related to mutation in both mitochondrial and nuclear genes. Nuclear genes are less known. We know quite a lot about the mitochondrial syndrome, particularly the MELAS and MERF syndrome that are linked with a cardiac and a cardiomyopathy phenotype. But we need to remember this is not just a catchphrase. Mitochondrial disease can present with any symptom in any organ and at any age. So if you see something funny, think about mitochondria. Of course, we have red flags. And cardiac red flags are the presence of an hypertrophic cardiomyopathy with or without AV blocks and or Wolff Parkinson-White, and we generally see a lactic, we generally need to look for a lactic acidosis. That is a typical systemic red flags in these patients. Dilated cardiomyopathy can be an evolution or can be an early presentation, particularly with myopathy. So, second point, when we need to think about a metabolic disorder. This is a very good question. Here we have Professor Rapezzi that suggested as what is the, let's say, the outline we need to follow with rare conditions. Looking at specifically at metabolic disease, well, we probably, the presentation is really heterogeneous, but we probably can define 4 typical presentations. A presentation in infants that is generally a really acute and severe presentation, and sometimes it's cause of a sudden infant death, unexplained infant death. A childhood presentation that is generally progressive, and young adult presentation that is generally a chronic disease, and in adults we have generally a mild phenotype, and of course we have exceptions because Fabry disease do not present before 35-year-old in males and a decade later in females. So same style, starting with family history. Let's exclude consanguinity. Let's exclude female to male inheritance, so it's linked. Let's exclude matrilinear inheritance. Personal history, let's look for funny presentations. Funny presentation, unexplained symptoms can be something we need to look for in metabolic, when we suspect a metabolic disorder. And of course we have an array of symptoms like sensory neural deafness, like retinitis pigmentosa, mental retardation, but probably the most important is the presence of myopathy. So muscle weakness is typically involved in many metabolic and mitochondrial diseases. And we can probably differentiate between disorders. If you have, for example, cramps on myoglobinuria, well, we probably are facing a GSD. If we have a muscle weakness after stressor, like fever or fasting or cold, well, it may be a fatty acid oxidation defect. Or if you have a chronic premature exercise limitation out of proportion of the intensity, well, we need to think about mitochondrial disorder. Of course, ECG is really important. I've stolen this slide from Professor Rapezzi, but it's really nice. And you can see that deposits can be typically in the conduction system. And we can have both a short PR or a long PR, particularly in end-stage disease. Echocardiography, of course, is really, really important for our diagnosis, and sometimes we can find also red flags. For example, a concentric hypertrophy, a biventricular hypertrophy, the presence of hypokinesia can be all typical of metabolic or mitochondrial disorder, and a massive hypertrophy can be typical of some condition like Pompe disease or Danon disease. And, well, MRI, of course, is nowadays something really important. We should consider MRI in all cardiomyopathies, and sometimes we can have also red flags, like the so-called back wall syndrome, so the hyperenhancement in the infero-posterolateral wall that is typical of Fabry disease. And in the future, probably with T1 mapping, we will have more insights in the differential diagnosis. I know you are scary from this slide. I'm scary as well. Let's try to think that we can have first line, second line, and third line tests. Okay? When we look for lab tests, that is really, really important, we need to start with CK and transaminase. These are important for all metabolic disorders. We can have specific patterns, I made really simple, with acidosis and ketosis in mitochondrial, so lactate pyruvate ratio increased. We can have acidosis or hypoglycemia with no ketosis in fatty acid oxidation defects. We can have hypoglycemia with ketosis in GSD. And of course, when we have LSD disorder, we should look for the enzyme on pepper filter. And biomarkers are also coming out really rapidly. And of course, genetics is really important to confirm diagnosis, but is mandatory when we have a female carrier, particularly in Fabry disease. I won't go through muscle biopsy or endomyocardial biopsy because we will probably look specifically at these tools later on. So, if I have time, clinical cases, strange guys. Let's start with this first quiz. Is a 2-month-old baby, thyroid to retrieve, hypotonia, increased transaminase and CK hepatomegaly. We have a severe hypertrophic cardiomyopathy with reduced ejection fraction, mild to moderate mitral regurgitation, ECG left ventricular hypertrophy with short PR. So I'm sure Dr. Kasky has the answer. But the answer is easy here because we have all the, let's say, systemic and cardiac red flags. So a floppy baby, organomegaly, increased CK and transaminase, and we have a typical cardiac presentation of Pompe disease. This is completely different in adults. This is a large family we have in Italy. And as you can see, the hypertrophic cardiomyopathy, don't look for an important hypertrophic cardiomyopathy in adults. You can have just let's say, concentric hypertrophy with diastolic dysfunction, with, you know, abnormalities that are segmental, but not really a massive hypertrophy in adults. And also, you need to start to look for an aortic and vascular phenotype. That is probably the most common phenotype in adults. Second, 10-year-old, so different age, so short stature, hepatomegaly, inguinal hernia, mental retardation. Here, the cardiomyopathy is not really an important issue, but we have a severe thickening of the valves. So, again, I think here we have all the systemic and cardiac red flags to help us reaching the final diagnosis, and particularly when we see an important valve disease so early in a baby, we need to think to something funny, a metabolic or collagen tissue disorder, okay? Or at least we need to exclude. So, again, different age, 35-year-old, previous transient ischemic attack, diabetes, bilateral deafness, proteinuria. Concentric hypertrophy, reduced ejection fraction, hypertrophy and short PL. Here we can have different, we can think to different disorder, but I think what really help us is the presence of diabetes and bilateral deafness. Of course, we can think about the Fabry disease, but the presentation is really aggressive. Diabetes is not really present in Fabry phenotype, and bilateral deafness is more common in Melas syndrome than in Fabry disease. And another point that is really important, look to the pedigree, and here there is a clear matrilinear inheritance. It is typical of mitochondrial disorder. So, we have a lot to do, as Perry said, in our busy clinic, but why we need to recognize rare disease? We need to recognize rare disease because we have therapies, and if we have therapies, we really need to start this therapy as soon as possible, particularly when we think about storage diseases. And I will close with our role, cardiologist's role in metabolic disorder. I think we have a double role. We are part of a team, and of course, we need to diagnose cardiac involvement, to risk stratify, and to manage cardiac involvement. But we and you all can be in charge with metabolic disorder. When you see something funny in your clinic, a cardiomyopathy and unexplained arrhythmias, and look for systemic red flags, try to recognize the disease. And we heard before, it is important to recognize diseases as soon as possible and to start the specific and tailored therapy as soon as possible. Thank you.